Our session today is the second part of antepartum hemorrhage, which is placental abruption. We talked in the previous lecture or previous session about placenta previa, and we define antepartum hemorrhage. And the second important cause of antepartum hemorrhage is placenta abruption. To start with, what is the placenta abruption? Abruptio is defined as bleeding following premature separation of normally sited placenta, i.e., the placenta is normally located in the upper uterine segment. Later on, there will be premature separation. This is one. What is the incidence rate? It is about 5% of all pregnancy. Although the majority of this is small and only visible on a placental examination after delivery. We can grade the degree of placenta abruption to three graded. Grade 0, here asymptomatic retroplacental clot seen after placental delivery. Grade 1, there is vaginal bleeding and uterine tenderness, visible retroplacental clot after delivery. Grade 2, reveal bleeding may or may not be present, but the placenta separation is significant enough to produce fetal compromise and retroplacental clot visible after delivery. Reveal bleeding in grade 3 may or may not be seen, but there are significant maternal signs. Uterine tetany, hypovolemia, and abdominal pain with late stage fetal compromise or fetal death. Whenever you see patient with antepartum hemorrhage and there is fetal death, you have to think by grade 3 placenta abruption. In this group is very serious group because 30% of cases will develop DIC. So, abruption has historically been associated with very poor fetal and maternal outcome. Perinatal mortality rate vary widely as the diagnostic criteria are generally clinical and broad. The minimal perinatal mortality rate is at least 4 per 1,000. This diagram shows you normal placenta, abruption placenta, and placenta previa. The other picture shows you how the placenta, when separated, either give you internal bleeding, which we call concealed ABH, or external bleeding, which we call reveal placenta abruption. What is the etiology and association? The etiology of abruption is unclear, but there is significant risk factor, which included previous abruption, family history of abruption, fetal abnormality, rapid uterine decompression, rupture of membrane with polyhydramnios, trauma, a chronic chorioamnionitis, smoking, abnormal placentation, for example, circumvallate placenta, preeclampsia, and underlying thrombophilia. It is clear that abnormal placentation in its widest context predisposed to abruption. This properly encompasses the last four associations, all of which may represent disturbances in placentation. So, abruption is an increase in the majority of thrombophilias, including factor V Leiden and prothrombin gene heterozygotes and homozygotes, protein C and S deficiency, and antiphospholipid syndrome. Other risk factor: women who had previous abruption have 6 times to have it again in the next pregnancy. Family history very important. Women who have a sister who has had abruption are at increased risk themselves. And because the placental abruption is associated with disturbed placentation, any factor associated with disturbed placentation may lead to abruption. For example, intrauterine growth restriction, oligohydramnios, fetal abnormality, especially aneuploidy, and abnormal umbilical artery Doppler velocities. This diagram shows you how the placenta is separated from the uterus. How we are going to diagnose this? As we mentioned in the beginning of the session, the diagnosis of the placenta abruption is entirely on clinical background. There may or may not be revealed bleeding. The woman may have a pain that either precedes or during the bleeding. The uterus may be irritable, and if large abruption is present, the uterus may be hard and tender. In grade 2 and 3, the clinical picture is usually clear, and the management will be dictated by both mother and fetal condition. In grade 0 and 1, may be much more difficult diagnosis. There will be much overlap between women with marginal bleeding and the bleeding of other causes. This is largely irrelevant clinically, as all women with ABH represent a high-risk group for whom surveillance in pregnancy is needed to be increased. This diagram shows you the type of bleeding: concealed, mixed, and revealed. Ultrasound is not good method of diagnosis placental abruption. Small area sometimes don't visualize. In acute phase, when there is large abruption, can be isoechoic and look like a placenta. So when abruption is clinically suspected, it is burden to manage with that as the diagnosis. So what is the other benefit of ultrasound in abruption placenta other than the diagnosis? The benefit is confirm fetal viability, assess fetal growth, measure liquor volume, perform umbilical artery Doppler velocities, confirm fetal normality as far as possible, or exclude placenta previa. The very important rule or benefit from ultrasound is to exclude placenta previa in antepartum hemorrhage. Is there is any rule for Cloher testing? Yes. Cloher testing should be performed in women who are rhesus negative. This will ensure that appropriate dose of anti-D is given. Should a large fetal maternal hemorrhage be detected, Cloher testing as diagnostic tool has not been shown to be of clinical value in determining whether pain or bleeding is secondary to abruption. This picture shows you abruption placenta. Management is specific to abruption. First question, when to deliver? The main management decision to be made with abruption is whether to deliver the fetus. This will be, of course, depend on the clinical picture and the gestation. Approximately 50% of women with abruption will present in labor, and the decision then must be how to deliver the fetus. When fetal compromise is confirmed at viable gestation, the aim should be to deliver the fetus. A study comparing neonatal outcome at gestation of viability suggests that even the caesarean section is a better choice for the fetus. However, even when the caesarean section is performed, perinatal mortality is high, ranging between 15 to 20% are reported. At very low gestation, vaginal delivery should be the aim. Labor is often quick, although prostaglandin can be used, they are rarely needed. This also two pictures that show you the difference between reveal and conceal. It is important when performing a C-section to alert the hematology, to arrange blood cross-matching as possible, whether there is time to delay to wait the result of a clotting screen, and the cross-matching will depend on the degree of maternal bleeding and the condition of the fetus. Thing to be remember that there may be already have been considerable unrevealed bleeding which may increase the blood loss well above that which has been revealed. يعني اكو كمية من الدم مريضة فاقدتها غير اللي هي جاية لنا بيها. Seek senior help if this is thought likely to be necessary. You have to expect heavy postpartum hemorrhage. As we know, antepartum hemorrhage is the risk factor for postpartum hemorrhage. If the fetus is already dead, as we mentioned in our beginning of our session, vaginal delivery should be the expectation, but 30% of these women will develop DIC and delivery should be expedited. The management is discussed further below. The time taken to achieve delivery will depend entirely on the rate of bleeding, the rate of changes in clotting study, and the clinical condition of the mother. Fortunately, delivery is usually rapid, and after delivery the DIC will usually begin to resolve. يعني مجرد ما احنا نطلع المشيمة تبدي ال DIC تقل النسبة مالتها. If the abruption is small, the fetus uncompromised, and the mother is well, conservative approach may be utilized. There can only be gain for the mother and fetus if there are benefits in terms of maturity and option to give steroid. If abruption is thought to be the diagnosis and the fetus is mature, delivery in controlled manner is probably the best management plan. After 38 weeks, in most cases of suspected abruption, delivery should be considered. يعني we don't allow our patient to reach up to post-term, for example, 40 or 39. Between 34 and 38 weeks, cases must be managed on individual basis. Where a conservative approach is undertaken, surveillance is very important. In acute phase, a period of inpatient management with twice CTG until stability is confirmed. Fetal growth must be serially assessed, and umbilical artery Doppler waveform analysis is also helpful. This is regard about the definition of placenta abruption, the grading, and the aim of our management. Now, we are going to talk about management of the women presenting with antepartum hemorrhage in as a whole, as either abruption or previa. Management and initial presentation. We have to assess rapidly the condition of the both mother and fetus is a vital first step. You have to take a quick clinical history in acute situation. A more detailed history can be taken once you stabilize your patient. Question should be asked regarding what is the question you have to ask? Date by previous scan, very important. Always if the patient come to you and have antepartum, you have to tell her where is your ultrasound, date by previous scan, amount of bleeding, associated or initiation factor, is there is pain, the history of coitus, trauma, leakage of fluid, previous episode of bleeding, previous uterine surgery, for example, induced abortion, surgically managed miscarriage, smoking, the use of illegal drugs, especially cocaine. You have to ask about fetal movement, very important. You have to ask about the blood group and position of the placenta if known from previous scan. Smoking increases the risk of placenta previa, placenta abruption, and marginal bleeding. This is a dose-dependent effect. Fetal growth restriction is associated with both marginal placental bleeding and placental abruption. The mother may have noticed a reduction in fetal movement. You have to ask about use of cocaine, and crack cocaine is strongly associated with abruptio placenta. How to assess the mother? In the initial stage, maternal assessment should be included. You have to take the pulse, blood pressure, uterine palpation for size, tenderness, presenting part. A vaginal examination must not be performed until a placenta previa has been excluded, either by previous ultrasound or you do ultrasound at the time of seeing the patient. Fetal assessment, which include whether the fetal heart can be healed or not, making sure it is a fetal, not maternal. The mother may be very tachycardic. If fetal heart is healed and the gestation is estimated to be 26 weeks or more, fetal heart rate monitoring should be commenced. The initial step takes very little time. Following this initial assessment, women will fall into one of the two categories. يعني راح نقسم الفيميل ولما سوينا الماترنال assessment والفيتال assessment to two types. Type 1, the bleeding is minor or settling and neither the mother nor the fetus is compromised, يعني stable patient. The bleeding is heavy and continuing and the mother or the fetus is or soon will be compromised. يعني المريضة حالتها وحالة جنينها غير مستقرة. الجروب الأول. Group 1. The bleeding is minor or settling and neither the mother nor the fetus is compromised. This is the most common group and is usually clearly apparent that neither mother nor fetus is in danger. Time can be taken to conduct a full and thorough history and examination. Once it is clear that the placenta is not low, you can do pelvic examination. to assess the degree of bleeding, to ascertain cervical changes which may be indicative of labor, to assess local causes, for example, trauma, polyps, cervical lesion, to take bacteriological sample if infection is suspected, high vaginal, endocervical swab, urine polymerase chain reaction, endocervical swab for chlamydia, plus viral swab if herpes is suspected. After a careful history and examination, it should be possible to use selected investigation to help establish a diagnosis. Admission. Further investigation, you have to do full blood count, Cloher testing in women known to be rhesus negative or in women with unknown blood group, grouping and saving of serum with blood cross match if there is continuing or severe bleeding, a clotting screen in cases of suspected abruption or heavy bleeding. Ultrasound is useful for measurement of fetal size, assessment of lacar volume, location of placenta in relation to the internal cervical os, establishment of fetal well-being. This is included by biophysical profile and umbilical artery Doppler polysymmetry. Ultrasound is not generally helpful in diagnosing abruption as we mentioned in our talk, beginning of our talk. Acute abruption can be difficult to see as they may have the same echogenicity as the placenta. It should be made clear that the ultrasound examination is primarily to assess the position of the placenta, the well-being of the fetus. Women are often disappointed if they have been led to believe the ultrasound will identify the cause of the bleeding. If the source of bleeding is fetal, the fetus is usually quickly compromised. This may present with fetal tachycardia, progressing rapidly to sinusoidal CTG and finally a terminal bradycardia. Very rarely, an Abbott test, which is rely on the resistance of fetal hemoglobin to denaturization by acid, can help if fetal blood loss is suspected. Cloher testing is mandatory for all rhesus-negative women. All RHD negative women will require 500 international unit NTD unless they are already sensitized. The Cloher test must be done to determine whether there has been a large fetal-maternal hemorrhage, in which case more NTD will be needed. The Cloher is not a useful test to differentiate small abruption from bleeding of other cause. Fetal cells may appear in the maternal circulation in as many as 15% of the women at some time in pregnancy, and lack of fetal cells in the maternal circulation does not preclude an abruption. When any pregnant woman complains of episode of vaginal bleeding in pregnancy other than confirmed causes of hemorrhage, cervical cancer must be excluded by direct observation of the cervix and cervical smear taken. This should be undertaken irrespective of her past medical or report of normal past cervical smear. Yani if we are not diagnosing local causes, when patients still have bleeding, you have to think by CA cervix, and you have to took cervical pap smear regardless of her past medical history or report of normal past cervical smear. Surveillance after limited ABH. Although some units admit women who have had ABH for 24 hours for observation, there is no evidence to suggest that this improves outcome once fetal and maternal well-being has been established. Management must be individualized, taking into account the suspected cause of bleeding, gestation, fetal assessment, and continuing maternal risk factor. The following must be borne in mind. No bleeding, however light, should be dismissed without full investigation. Once ABH has occurred, the pregnancy becomes high risk, and management plan for ongoing fetal surveillance must be formulated and discussed with the mother. Women must be advised to watch for warning signs such as decrease in the frequency of fetal movement, further bleeding or pain, and should be assessed again should any of this occur. Planning for the rest of pregnancy. If the bleeding settles and the mother is discharged, a clear plan for the remainder of the pregnancy should be made, even if the cause is thought to be minor. Extra fetal surveillance is needed as a higher fetal mortality rate is seen compared with background. Fetal surveillance for growth and well-being should be instituted as guided by the clinical picture. If all remains well, induction of labor at term is not needed, but the degree of surveillance after the due date may need to be increased. Group 2. This is all that we talk if the patient have minor or subtle bleeding. Group 2 اللي هو severe ongoing bleeding compromise mother and or fetus. Here delivery must be expedited if the mother is compromised. If the fetus is compromised, the decision to deliver will be based on the gestational age. In most cases, delivery will be indicated. The method of delivery will be determined by the cause and severity of bleeding, the fetal gestation and status. Women with major hemorrhage from placenta previa will need to deliver by C-section. Placental abruption causing maternal or fetal compromise necessitates delivery. If the fetus is already dead, vaginal delivery after stabilization of the mother is usually the safest option. However, if the bleeding continues and the other condition cannot be stabilized, delivery should be achieved by the quickest method, which may be by C-section. Coagulopathy will only begin to resolve once the placenta has been delivered and may be severe enough to warrant replacement with fresh frozen plasma, cryoprecipitate, and platelet. These women usually very quickly. These women usually have very quick labor. Epidural or spinal anesthesia must not be used if the clotting studies are abnormal or not available. CVB lines can be useful, but should be sighted through an antecubital log line and not sighted or removed until clotting is normal. It can be difficult to measure obstetric blood loss accurately, as the loss may be concealed, placental abruption, or diluted by amniotic fluid. Major hemorrhage can be identified by blood loss and or vital signs. If blood loss more than 1000 ml يعني بطلين دم. Disturbance of conscious state, the patient disturbs consciousness. Systolic pressure less than 100 milligram. Systolic. Blood pressure pulse more than 120 beats per minute. Reduce peripheral perfusion يعني تيجي تشوف المريضة cold. Disturbances of coagulation due to the loss or consumption of a platelet and clotting factor may occur during hemorrhage. DIC is the coagulation problem most often encountered in obstetric patients. This is and the other complication. Fetal or maternal death. Adult respiratory distress syndrome, renal and hepatic failure are more likely to occur if adequate replacement of the blood volume is not investigated rapidly. يعني ربما تصير كل هاي المشاكل إذا مريضتنا ما عودناها بطريقة سريعة. What is our aim of management or treatment of major hemorrhage? Rapid restoration of the circulation, blood volume, and oxygen carrying capacity, cessation of further blood loss, restoration, maintenance of normal blood coagulation, delivery of the live fetus where appropriate. Resuscitation should aim to keep the hemoglobin concentration above 8 grams per deciliter, the pulse rate below 1000 beats per minute, and the systolic blood pressure above 100 millimeter mercury. 4 units of cross-match blood should be available at all times. The British Committee for Standards in Hematology recommended aiming to keep the platelet count above 75,000. And the prothrombin and activated prothrombin time less than 1.5 multiplied by mean control fibrinogen more than 1 gram per liter. The success of a treatment is depend on the careful organization as well as traumatic treatment and the use of appropriate blood product and non-blood volume The patient, her partner, and relative must be kept fully informed. Expander. When major hemorrhage is identified, first of all أول نقطة نعيد نذكر بها دائما call for help. Call for help. The immediate team will consist of the obstetric specialist register, the obstetric senior house officer, the anesthetic register, the senior midwife. The consultant obstetrician and the anesthetist should be informed. A member of staff should be nominated to run, sample and record events. The hematology laboratory must be informed that there is a major obstetric hemorrhage. This is one. Secondly, you have to give oxygen facially. 10 to 15 liters per minute. Hypoxia will reduce uterine contraction. You have to insert 2 intravenous cannula, 14 gauge, brown, orange, 1 into each antecubital fossa. Take 30 cc of blood for full blood count, clotting screen, include fibrinogen and fibrin degradation product or D-dimer if DIC is suspected. You have to cross-match 6 units of blood. Urea and electrolytes and liver function. Commence the following infusion. شطط المريضة up to 2 liter normal saline يعني لترين normal saline or Hartmann solution. Colloid up to 1.5 liter يعني 3 بطالة. And cross match RH negative blood or group specific blood if a clinical condition is critical. Cross match blood as soon as available. Cross match blood is the ideal, but crystalloid first and colloid second should be used until blood is available. The group ORHD negative blood should only be used as a last resort, but can be life-saving when the hemorrhage is severe. The group O RHD negative blood must not be given to patients known to have anti-T antibody from their antenatal record. Fluid should be warm as cold injury exacerbate DIC يعني لازم انت تدفي الفلويد إلا تنطيه للبيشنت otherwise cold injury exacerbate DIC. 6. Set an indwelling catheter to monitor urine output and aim to keep output above 30 ml per hour. One member of staff should be assigned to record all the following: the pulse, blood pressure, CVB line, half hourly if a line is present, continuous fetal heart rate when appropriate, fundal height abruption, postpartum hemorrhage, urine output, fluid input, type, volume, and IV set, any drugs administration, time, with type, with dose, or measured blood loss. The senior obstetrician present should coordinate and manage the clinical situation, i.e. PROMET, treatment of the cause of hemorrhage, adequate fluid replacement, and regular checking of full blood count and clotting status in order to prevent and treat DIC. A major hemorrhage box is an asset on an acute unit. It should contain everything needed for initial resuscitation, which is include fluids, cannulae, tourniquet, blood bottle, and forms and oxytocin, etc. And thank you very much for your listening.